Hello and welcome. My name is Vineet Serene, and I'm the President and CEO of Kindamed Incorporated. It is my great honor to welcome you to our inaugural educational event featuring three novel technologies for the knee joint preservation surgeon. Our event today will feature three world-renowned sports medicine surgeon specialists, each of whom is also an accomplished educator and prolific researcher. Today, they will share with us how they deal with patellofemoral malalignment, osteochondral, and other types of lesions and defects, and end-stage patellofemoral osteoarthritis. Before we kick things off, I would like to briefly introduce our speakers and moderator. Dr. Seth Sherman is a third-generation team physician and surgeon and is an associate professor of orthopedic surgery at Stanford University School of Medicine in California. He is head orthopedic surgeon for Stanford Cardinal Football and serves as Stanford's Sports Medicine Fellowship Director. Dr. Sherman has subspecialty and research interests in knee joint preservation, cartilage restoration, and the patellofemoral joint. Dr. Sherman will be presenting on tibial tubercle osteotomy with the novel MD3T system. Dr. Brian Cole is an orthopedic sports medicine surgeon and managing partner at Midwest Orthopedics and is a professor of orthopedics, anatomy, and cell biology at Rush University Medical Center in Chicago. Dr. Cole's research interests include cartilage restoration, orthobiologics, and minimally invasive surgical techniques for the treatment of the knee, elbow, and shoulder. Dr. Cole will be presenting on deep cleaning of allograft bone with the Carbojet to improve graft post healing. Dr. Adam Yankee is a sports medicine orthopedic surgeon at Midwest Orthopedics at Rush in Chicago. He is an associate professor and director of clinical research, as well as assistant director of the Cartilage Restoration Center at Rush. Dr. Yankee's research interests include advanced arthroscopy, shoulder replacement, along with a special focus on patellofemoral dysfunction and cartilage restoration. Dr. Yankee will be presenting on patellofemoral arthroplasty with the custom patient-matched Kindamed system. Dr. Sean Kelly will serve as our moderator. Dr. Kelly is a fellowship-trained sports medicine surgeon with Colorado Orthopedic Specialists and is a former professional athlete who now specializes in joint preservation, knee and shoulder injuries, and robotic-assisted total joint replacement. At this point, without further ado, I'd like to turn it over to Dr. Sherman, who will get us started.
Seth Sherman from Stanford University, and excited to talk about an emerging technique that I've been using for the last several years now, tibial tubercle osteotomy using the MD3T system. TTO can be a powerful operation correcting patellofemoral malalignment in the setting of chondrosis, instability, or combined patient problems. However, when to do a TTO is a moving target and remains somewhat controversial. For me, in 2023, going into 2024, I'm typically using this anteromedialization or anterization to unload cartilage lesions. And I'm also using this on occasion to correct a lateralized force vector in the setting of patellofemoral instability. I use distalization for extreme cases of patella alta, both to improve stability and also on occasion to offload distal patellofemoral chondrosis. And then I use TTOs in some salvage situations, such as correcting patella baja several times per year. We've all unfortunately been there and have seen both early and late complications with standard tibial tubercle osteotomy types. This can be quite humbling. And I think there is a great opportunity for improvement in this space, hence my interest in the MD3T system. To go forward, we must look backwards. And interestingly, TTO goes back about 130 years. Rue described this osteotomy, which interestingly is quite close to where we are today in 2024. Hauser unfortunately took us slightly back in the 1930s and 40s, taking the tubercle and placing it posterior and medial. This had devastating consequences, including severe BAHA and osteoarthritis. This is unfortunately a patient of mine that I had to correct, doing a very strange proximalization, anterolateralization osteotomy and patellofemoral arthroplasty to try to get their quality of life back. And so not every TTO can be helpful. We need to understand why we do TTOs. So for example, the Elmsley Triot in the 60s was created as a surgery for patellofemoral instability. In contrast, the McKay procedure in the 70s was an anterization to unload the joint itself, which is a good concept, except the amount of anterior unloading, unfortunately, in a lot of these cases, led to anterior tissue necrosis. John Fulkerson and his classic anteromedialization, which was initially described as a pain procedure, has become really an American standard for dealing with both pain and instability in the setting of patellofemoral malalignment. This is a great operation, although it's technically quite challenging. You need to be proficient with it. It's a large chunk of bone. There is a fracture risk, some inherent instability if you're going to also try to distalize. And you're also really married to the angle of your saw blade. And so these are some of the thoughts that might lead towards novel constructs. To go forward again, we must look backwards. And I pay homage to the unfortunately very recently late and amazingly great Al Merchant. I'm so lucky to have met him at the Patellofemoral Study Group meeting. And when I moved to Stanford 5 years ago to spend a real good amount of time with Al, learning about his passion for the patellofemoral joint and his real innovative spirit. Al, of course, was the champion of the merchant view, but Al also had been working for decades on his tibial tubercle osteotomy. And these are kind of his thoughts and descriptions. You can see here kind of a composite series of wedges where you can mix and match them to achieve your desired amount of corrections. And so here's kind of an animation of Al's design concept, taking out that primary wedge, which is attached to the patella tendon, utilizing as needed a secondary wedge, and then basically swapping their positions to do medializations or anteromedializations. I thought this was very intriguing for several reasons. One, it's safe. And it seems actually less invasive than some of the larger osteotomy types. You're really cutting inside the medial and lateral cortices, which will allow you for minimal soft tissue dissection and potentially a reduction of some fracture risk. The technique is modular. As you'll see, you can use this for single plane or multi-plane corrections, which can be very powerful depending on the type of patient that you choose. It's precise and reproducible. We can measure and we can put it exactly where we want it in all of the different planes. And I think as are most important, it's really a teachable situation for the next generation. I can show my fellows this set, this system. They can play with it in the lab. They can do it with me in the OR, and then they've gone off into their own lives and practices and have done this on their own. Sometimes if you're freehanding osteotomies and we're taught to freehand, the translation between your mentor who's an expert and you who is a beginner can be really scary those first few years of practice. And so here's kind of what this looks like. This is the primary wedge cut on a sawbone. You can see how you can take the wedge out. You can put bone graft underneath the proximal aspect, and you can effect very easily an anterization type procedure to offload the PF joint. You can also, if you want, just take that wedge out, do a slope correcting osteotomy, and put the wedge right back where it belongs. So that's a really easy way to do a TTO. Similarly, you can take out that primary wedge cut. You can take off with a rongeur a few millimeters of the distal aspect of the primary wedge. We can do what Al called widening the kerf. And with just those simple maneuvers, we can very easily distalize 8 to 10 millimeters, which is the typical amount. Whenever we distalize, we always want to bone graft that proximal buttress to reduce your risk that it's becoming unstable. But this is a very, very nice and contained way to do distalization that I think will likely lead to less risks with the problems with the distal hinge. Here you can see taking a secondary wedge and switching spots with the primary wedge. And this is a straightforward way to do a pure medialization or an Elmsley triot. Basically, the width of the secondary wedge equals the amount of medialization that you'd like. If you're going to do an anteromedialization, then you need to use this chart or grid to tell you the width of that secondary wedge cut. So for this example, if I have a TTG of 22, I want to medialize by 10 to get it down to 12. I want to anterize by 5 millimeters. Then I will make a 7 millimeter secondary wedge cut, as you see there in red on the far right. Once you make that secondary wedge, then you basically transpose, and then you can measure precisely the amount of anterization and medialization. In this kind of an example, there is a bone void, and so you do have to use synthetic bone grafting, which can also add expense, but also add some nice stability to the construct. Here's a short surgical clip. This is an anterolateral exposure, which can be used for lateral lengthening and also used for cartilage restoration and MPFL. You can see how there's very minimal dissection of the anterior compartment. I use very limited amounts of fluoro. It's really mostly by feel. I use that lateral cortical finder to stay within the cortices, placing my primary wedge guide, and then making my primary wedge cuts. Again, staying within the medial and lateral cortices, going just above the patella tendon, completing the cut. In this example, I did not need to make a secondary wedge cut as I was doing more distalization than medialization. And so you could see going through those steps of taking off a small amount of the distal wedge, widening the kerf, and then placing the tubercle in my exact position that I want and pinning it in situ after measuring precisely distalization, medialization, and anterization. We can take the knee through a range of motion arc. We can look at the clinical Q angle near extension. We can look at what we call the tibial tubercle sulcus angle, which you want to be 0 degrees at 90. You basically want it to be straight down the middle. And if you're not happy, you can actually correct this on the fly in any of the planes that we just described. And then in standard fashion, once you finish your TTO, you can go on with your final soft tissue stabilization, in this case, an MPFL reconstruction and lateral retinaculum lengthening. You can see here the final x-rays that we can obtain. You can see the calcium phosphate bone graft that is proximal. I use 5/0 headless screws. I typically want to aim for a Catan-Deschamps ratio of 1.1, and I'll try to make that TT sulcus angle of 0 to normalize my lateralized force vector. Here's a patient who has bilateral chronic recurrent patella instability, almost every risk factor, including severe trochlear dysplasia, patella alta. He has a large J sign. He has severe underlying chondrosis with painful swelling, mechanical symptoms between his instability episodes. You can see here on his scope pictures what this looks like. You can see the dysplasia without chondrosis on the trochlea side. And so for him, we really have to take a comprehensive approach. We did a large osteochondral allograft for his patella. We do a tibial tubercle osteotomy, both anteromedialization and distalization to correct his malalignment parameters, as you see here. We did what's called a Lars Peterson or an entrance grooveplasty to help deal with his trochlear dysplasia. You can see on the right how there's no further J sign. There's centralized tracking throughout the range of motion arc. And it's interesting when complex and challenging patients like this come back for the other side. I think it just speaks to the power of our abilities at this point to perform high levels of patellofemoral joint preservation to reduce pain, instability, and improve quality of life. Briefly, I just want to show you a summary that I presented at Herodicus. This was our first 48 patients at Stanford. We're now up over 70 patients and collecting data actively. But just to give you a sense, the majority were anteromedializations, but a third of these patients also included distalization, and 6% were either isolated single plane anteriorizations or distalizations. The age and BMIs were as you'd expect of an active patellofemoral cohort, around 25 years old. The gender was predominantly female. The activity levels were predominantly recreational, but some higher level athletes in this group. It was a mixed bag, a third of patients with pain, a third of patients with instability, and then one third who complained of both of these problems. You can see that concomitant procedures, about half the group was subluxers or dislocators and had soft tissue stabilization combined with their TTOs. One third of these patients had either a MACI procedure or osteochondral allograft. Here's some preoperative measures. You can see the TTTG and TTPCLs lingering in that 15 to 20 for TTTG and about 20 to 24 range for TTPCLs. We can see in the distalization group, the Catan de Champs were 1.4 or above, whereas in the non-distalization group, the CD ratio was 1.1. We can see this is still short-term follow-up, but ongoing. What I'm happy with are the correction precision. We can really distalize correctly and precisely to 1.1. And when we didn't want to distalize, we didn't change the patella height at all. This is very important early. The adverse outcomes were small, 16.7%. Really minimal amounts of no deep infections, only some superficial infections requiring antibiotics, a smattering of stiffness, and only one hardware removal. I think the most important things were that there really were no early issues for revision, hardware failures, non-union, malunions, or fractures in this initial series. No difference in adverse outcomes at short-term follow-up with distalization versus non-distalization. And with the headless screws, I've really reduced my rate of hardware removal substantially from about 20 to 30% or more down to what you see here after a year or more of follow-up. Obviously, we're getting larger numbers. We're doing prospective, subjective, and objective outcome collection, longer-term imaging, advanced imaging to really precisely look at these outcome parameters and to look at the corrections in 3 dimensions. We're partnering with gracious John Fulkerson, looking head-to-head with his procedure. We're doing this in the laboratory and hopefully also can do this in clinical comparative studies and follow-up. In summary, TTOs for patellofemoral pathology are like a toilet plunger. It's a familiar tool and it solves problems. This may not always get to the core of the issue. The lateralized tubercle isn't always king. There are issues with rotation on the femur, the tibia, combined issues, trochlear dysplasia, issues with valgus, and really all of the above. But when it comes down to it, if you need to do more than just a soft tissue procedure, the most simple, safe, reproducible one, at least in the American arsenal, seems to be the TTO. And this is borne out in the literature to get the job done with really low recurrence rates and high rates of patient satisfaction with acceptable complication profile. So I hope I've shown that the early safety of the MD3T system is encouraging. The potential benefits to me are the system modularity in real time, precision, reproducibility, and teachability. And I'm excited to continue to follow these patients, to report our outcomes, and to work really with Kindamed and their excellent team across the country to get other surgeons to try this and to help make this better for the next generations. And I thank you very much for your kind attention.
Sean Kelly, Colorado Springs with Colorado Orthopedic Specialists. Um, I'm a sports knee and shoulder surgeon that also does a fair amount of arthroplasty, but mainly sports and cartilage restoration. Um, First of all, Seth, great talk and great presentation. I think that Sawbones was great for showing really the simplicity of the system. And I was hoping maybe to get a couple more tips on, what surgeons that may look at a pretty daunting procedure could do to basically improve their outcomes and also even simplify the procedure itself. When you have that patient that has maybe a little wider patellar tendon, do you have any tips um, on making those first cuts so that you don't get into the tendon itself? What do you do when you see that little wider tendon?
Yeah, a lot of the time, because of that lateralized force vector, the patella tendon comes very close to the lateral cortical edge. And so if you put the guide on, it can be, challenging to stay within the lateral cortex for that first cut. I tend to not worry so much about that. I actually sometimes take a 2 to 3 millimeter strip off of the tendon on the lateral side and or peel it up from lateral to medial so that I'm staring right at the lateral cortex when I place the guide on the lateral side. And so I really don't want to violate lateral cortex. On the flip side, I will never, ever take any medial tendon out. So I will always either, if the primary wedge cut is the primary guide is not wide enough to accommodate for the tendon, I'll use a very easy outrigger extension and put it just medial to the medial border of the tendon, and that will be my initial medial cut. So while I'm pretty liberal to take a little lateral tendon or to peel it up on the lateral side to make sure I stay within the cortex, on the medial side, I'll never do that. I'll always stay medial to the patella tendon. And I found that I always have a really nice size tendon. If you think about it, we're taking out in BTB autographs, what, a centimeter in the middle of your tendon. And, we're doing fine with that. This is very minimal amounts of tendon excision, if any.
Sure. And then are you using the outrigger that Kindamed is part of the set, or are you using some sort of different outrigger when you're
Yeah,
trying to?
so the Kindamed set will walk you through very easily how to take that initial primary wedge cut and how to set up for your secondary wedge cut if needed. It also will have that outrigger that will allow you to stay outside of the medial border of the patella tendon for that initial cut as well. The guides at this point are very ergonomic. They're self-contained for the saw cuts. We also have iterated to make it even easier to make that proximal cut, which can also sometimes be daunting with less visualization just above the patella tendon insertion, and very precise measuring tools for anterization, medialization, and distalization, so that you can really put it where you intended to in your pre-surgical plan.
How much anteriorization will you accept? I know we're all worried a little bit about skin necrosis there. Do you kind of have a rule of thumb when you're anteriorizing somebody to offload the joint?
So in general, I'm only anterizing if I'm offloading chondrosis. So I include that in cases of chondrosis. I'm fine including that not only in my medializations for chondrosis, but in my distalizations if I have the same kind of patellofemoral pathology. The classic issues were when you're getting upwards of the centimeter to 2 centimeters of anterization. For me, in general, I'm anterizing maximally around 8 millimeters, and I can measure that precisely. So that's pretty much my target for anterization. At this point, I know Adam Yankee, our colleague, who's also on the program, has looked at a sagittal TTTG measurement. I've not really been using that yet to see if we should or how much we should anterize. It's really more if I'm unloading or not, then I'm going to anterize 5 to 8 millimeters in general.
Yeah, I think that the ability to distalize with this system is absolutely fantastic. What do you tell that surgeon that they're not planning on distalizing, they're medializing, or they're offloading the joint, and they say, "Well, I could use some other system." What do you tell that surgeon
Yeah, no,
about this system? for
I think
that.
of all the things, this is the biggest game changer. This is what had David DeJour excited when I kind of showed this to him, and is similar to how some of the Europeans do their distalization cuts. I stood up at ANA and presented my cohort of distalizations using standard and classic techniques, and the risk of complications was like 12% versus 0 to 1%. And we've had fractures, we've had it unhinged, I've broken screws. And so that's scary. This construct with just that single primary wedge cut, widening that distal kerf, taking off only 2 to 3 millimeters of really not even essential bone for the final fixation. When you put the wedge into that distal uh, uh, bed, it fits like a glove and it's really stable there, both contained on the medial and lateral cortices. And then you bone graft proximally. It just feels like a much more comfortable and stable osteotomy. Of all the corrections you might do with a TTO, I think for instability, the one that would be universally accepted across the world would be correcting extremes of patella alta. So the Catan de Champs that are above 1.4. There's a lot of debate whether medializing or AMZs or any of this has a role in instability, frankly, whereas other deformities might prevail. But Alta is something that we all think matters, and having a straightforward technique to distalize safely, I think, is critical.
Yeah, I've been pretty amazed that you really don't have to nibble too much bone off the end of that. 2 to 3 millimeters, like you said, will really buy you quite a bit more distalization, especially when you widen that curve. And I think you've shown in another video, if you leave a little strip of that periosteum, it sure does make for a nice repair, right? At that distal aspect of the.
And typically that's only 8 to 10 millimeters, and you can do some very simple orthopedic math, just to get your CD ratio from 1.4 to 1.1. I'm always looking at lateral fluoros, comparing to their, sometimes normal, sometimes abnormal opposite knee. So I think over distalizing can be a big problem. Iatrogenic patella baja, increasing pressures, pain inflection, chondrosis. So, I think appropriate distalization and slight under distalization, just getting it below the threshold by which you wouldn't consider doing it at all. So below 1.2, I think we would not consider distalizing.
Sure. When you distalize, what's your go-to graft? I mean, are you using the osteo repair bone, or are you taking a cortico cancellous graft? What's kind of your go-to there, and are you seeing much of a difference with the osteo repair bone void filler?
I think when you look at the paucity of evidence on proximal buttress and using a variety of autograft allografts, I don't think there's much difference, at least in the literature. So it's dealer's choice, and there are obvious cost concerns. I typically will use the osteo repair. It is very easy handling properties. It sets up extraordinarily quickly. It will slowly kind of integrate and remodel over time, but I'm very comfortable and confident with that repair. For an anterization, I will sometimes put a corticocancellous bone underneath that anterization, the primary wedge cut. That was kind of the Play-Doh in the example that you saw in the video here. But other times I just put the synthetic calcium substitute underneath the wedge and allow it to set, and then you can do your screws afterwards or before. It's really dealer's choice which way you choose to do it.
Sure. And that osteo repair, it's nice if you overfilled a little bit. It's very easy to remove. It's not, you don't worry about it getting sticky on you too quick, but it does set up quick, which is nice. So it kind of gives you kind of both of those options. If you overfill that, you can.
And it's absolutely drillable. So, one
Right.
of the knocks on just the standard AMZ here, with obviously a classic Fulkerson, we're not needing to bone graft it. And so you do have to, you create a void and you do have to bone graft it. That's become kind of, part of the process for me. And it does add, once it sets up, quickly, it is really, strong at time zero. I move these with impunity in the operating room. I really don't have any, issues moving them right away post-operative. Al Merchant was getting on me to accelerate my rehab protocols. I've been reluctant just because of the early series. I just have kept it pretty standard, but he was always adamant that I could put weight on it and, start doing more and doing more early. So I think in a subset, that'll be my next iteration of clinical investigation, really trying to accelerate more than even the accelerated protocols that are out there.
Sure. And you mentioned you use a headless screw. Do you have a go-to size on that for your screws?
Yeah, I think again, screws can be dealer's choice. I had a good amount of hardware removals with headed 4.5s. You can do tricks, obviously, like recess them. Andy Casgarius talked about using smaller I think 3.5 screws, three of them. These are 5.0 headless screws. They're positional, so they don't, once I have it in the right spot, it's not really compressing it down in any major way. It's keeping the tubercle pedicle where I wanted it to be. And I've had very little hard removals. For the ones I've gone back on, which is a one in that series, and then I think one more. I've gone back for other reasons, not for specifically pain. So if I'm going back for stiffness or a second look for cartilage at a year or more, I'm removing the screw just as because I'm there,
Sure.
frankly.
Yeah. I've been going to a 4.0 screw headless, and I haven't seen any issues there. So, how about basing your skin incision? I know we all get a little worried about one, are we going to deal with some necrosis of the skin, or is it going to be symptomatic? Do you go pretty midline, or do you cheat one way or another? For the surgeons that maybe don't have as much experience
Yeah.
with tibial tubercle transfer, any tips where you base your skin incision?
Yeah, I mean, for me, a lot of my practice in patellofemoral is, revision, complex, salvage, or just really tough problems. And so, my skin incisions, as you saw, are maximally invasive, and then my deep dissections are meticulous and minimally invasive and soft tissue sparing. Still, you want to, I don't use bovies in the superficial soft tissues. I go straight with the knife. I try not to make big skin flap, just use what you need. My workhorse incision is just off the tibial crest, so just lateral to the crest, and then I'll extend that up towards the lateral aspect of the patella as need be. I find that it's hard to do lateral lengthenings and to access the joint laterally if you're not on the lateral side with that approach, whereas it's very easy from an anterolateral extensile approach to sneak over to the medial border of the patella for an MPFL reconstruction, and then just make a very small additional posterior medial incision for my femoral aspect of my MPFL. So most of these cases, I'm not doing an incision here, here, and here. I'm doing one reasonable sized anterolateral extensile approach. You can even get much less invasive if you want. With this guide system, when you get savvy, you can really just center a smaller incision over the patella tendon insertion on the tubercle and slide the guide distal under the skin. So if you choose to do that, it's safe and actually much easier to do that probably than with an unguided system. And so I think that for those surgeons who are very cognizant of that and in primary situations and in petite, young females who are conscious of the size of the incision, I think that's totally doable.
Yeah, I was going to mention with those smaller patients, that seems like a great way to do that. Take out some of some of the things you worry about with violating the cortex and things like that. And I'm glad you brought up the retinaculum lengthening. I'm assuming you do that on most all of your procedures are going to address patellar instability or things like that. We know that if we don't correct those soft tissues, a bony procedure isn't going to necessarily correct these. We've got to let that patella recenter itself where it properly should. I know without a technique video, it's a little hard to describe that, but what do you do with your lateral retinacular lengthening? What are some tips and pearls? I know it's hard to talk about without a video, but do you have some tips or pearls with that?
Yes, I follow a technique taught to me by Liza Arendt and also by Jack Farr. Basically, try to exploit the lateral planes between the superficial oblique layer, which is really an expansion that comes off of the iliotibial band and attaches to the lateral border of the patella. And I'll basically take that off the patella border, peel that superficial layer posteriorly, about 2 centimeters or so. Then I'll take a knife through the deep transverse layer, which is very thickened usually. And when needed, I'll go through the third layer, which is that slimy, deeper capsular layer to enter the joint. And so basically, by doing the cuts at different levels, the superficial cut right off the patella, the deeper cut 2 centimeters posteriorly, I can pretty much marry those edges and do a very nice 2 centimeter or so lengthening. And so, I think for most of my cases where they have profound malalignment, lateralized vector and or distalization, I'm adding the lateral lengthenings. And certainly that's an easy way to get into the joint for Macy's or osteochondral grafts. And so, yeah, I think, obviously lateral retinaculum in and of itself, it's a secondary restraint to medial translation. And so in as opposed to doing lateral releases along with your MPFLs, I think the lengthening when it heals, it's kind of a final buttress. It can just add some more stability, but you get rid of that fixed retinacular tightness and patella tilt.
Sure. Yeah, no, that's great. You mentioned that you get these patients moving pretty quickly. Just you feel like you've got great fixation of that bone. Are you doing anything? I mean, since you've started using this system, do you feel like you're able to speed up their rehab anyway? And obviously, there's a lot of concomitant procedures that you're protecting, but with this system versus, say, a freehand cut or some other system, do you feel like you've been able to speed up their recovery and rehab because you can get them potentially bearing weight a little quicker, moving a little quicker?
Yeah, I haven't routinely across the board adopted an accelerated protocol of like, let's say weight bear is tolerated at 2 weeks with the brace locked. I think it would likely at this point with my 70 plus patient experience, seeing how they, react and seeing that I've had, really a negligible amount of issues. I think that's kind of in my process and I'm very comfortable planning that and with the right patients doing that. And so I think that's my next iteration. What I will say is that because when you do a standard Fulkerson, especially a steep cut, when you're coming out laterally, through that cortex, you have to dissect down the entire anterior compartment and put a pretty big retractor there. And that's a lot of stripping, and that can bleed into the compartment or around it. I basically take off 2 to 5 millimeters maximally, and mostly just the attachments to that top of the lateral cortex, as you saw. And so my anterior compartment is essentially unscathed, and I think that translates into reduced pain and reduced bleeding risk in and around the osteotomy. Any bleeding is contained by the medial and lateral cortex, and it's also tamponaded by the fixation and the calcium substitute. So I've been very happy with that, and I think it leads to just patients at week 1 and 2, looking like they've had less of a major surgery than what my experience was in my early, 1 to 5 years.
Yeah, I mean that's where a lot of surgeons get a little scared. Even good knee surgeons, they really worry about that, stripping the compartment. Obviously, there's some scary stuff back there, postoperative hematomas and things like that. And that's been my experience also. You really don't worry about that because everything's contained within the bony defect that you've created with the system.
Sean, one other thing we didn't mention that's interesting, and I think we have to bear this out with advanced imaging before and after and modeling. If you look at the way this osteotomy goes, you're basically taking a tubercle that's, let's say lateralized, and you're not just translating it along an axis like you would for an AMZ. It's actually sort of a derotation. It goes from one side to the other. Now, whether that can or does or should, compensate for subcritical amounts of femoral rotation or tibial rotation or joint rotation. I just think it's an interesting aspect of this that might be under discussed and under represented here that I think is important because, femoral anteversion and external tibial torsion are very profound risk factors for patellofemoral instability. And those surgeries, in my mind, are even way scarier than conquering things at the tubercle. If this tubercle osteotomy can, in some way, shape, or form, also address, to some extent, rotational issues, I think that's interesting and is worthy of further, thought and study.
I wonder if I could ask you a question. So when you're doing your anterization component, are you taking the secondary wedge and then putting it underneath the wedge that you're excising? Is that how you're doing it to anteriorize it?
So if you're only doing anterization, then you're
Yes,
only taking the.
medial. Yeah, what are you doing? What are you doing to anteriorize when you go? Because my most common TTO is anterior medialization. So where you, it's obviously it's very easy to see where you get the medial component because you're taking a secondary wedge out, you're moving it over, and then you're jumping over and putting the secondary wedge on the other side, right? That's what you're doing. So is that correct?
So
So
if
when
you're,
you
yeah,
realize it, you make a space for it, you move it over, and then you take the other piece and bring it back on the other side of it. Is that correct?
yes. If you're
Okay.
doing a pure medialization without anterization, the secondary wedge width is actually quite big, right? It's 8 or 10 because it's just a pure Elmsley. And
Right.
so that one is just a pure swap, one for the other. And you don't need bone graft for that one. However, I don't think you or I do many straight medializations, mostly because we're adding the anterization component to offload. And so when you're doing the anteromedialization, the width of that secondary wedge is actually pretty small. I mean, you can template it out, but it's only 5 or 6 millimeters wide. And the reason is as you anteriorize that primary wedge, it actually is also medializing the whole kind of insertion of your patella tendon. And so when you look at that and you kind of have to play with the sawbone and then look at that in the lab to understand that concept, I really, in a lot of cases, I'm not even using that secondary wedge for any major aspect of the AMZ. I'm actually just bone grafting that void. And then I'll shove the secondary wedge into the bone graft substitute, but it's very different than just doing the straight large one-for-one swap of an Elmsley. It's more of a bone void that I have to fill with the synthetic calcium phosphate. But really that's a product of the way the osteotomy cut is designed. So when you're anterizing, that really will affect a significant amount of medialization as well. And so that translates into having to take really a small amount of that secondary wedge to get your typical, 10 millimeter medialization.
But are you putting bone graft, the bone or the synthetic bone behind it?
Yes.
So are you pulling it out or just lifting it up and laying it
Behind
behind
and lateral. Yes.
and doing it lateral and that's shoving it medially at the same time bringing it forward?
Yes, and you can also, before you do that step, the synthetic bone graft, packing under and lateral, you can actually take some of the autograft bone in the bed and move it from lateral to medial. So I do that as well. So, once I take out the primary wedge cut, if there's any bone that's really just on the lateral side of that, I'll just take a curette and move it over medial. So that sits under the primary pedicle as well. And so, I think both of those things, and sometimes if I want a more rigid resting point for my primary wedge, I'll put that small cortical cancellus. I'll just contour in a small cube and put that right at the base, and then that isn't going anywhere. I mean, I can tamp that to my 8 or 10 millimeter anterization, measure it precisely, and I'm really happy with that fixed spot. It's
And
not going to subside.
which components are disposable and which things are reusable?
So the majority of the set at this point is reusable. So I think once you have it kind of at your OR, and you can use it as you need. The
Thank
obviously the synthetic bone graft aspect is separate and proprietary, and then the screws are whatever dealer's choice company's screws you use.
thank you.
At this point, without further ado, I'd like to turn it over to Dr. Cole.
Hello, I'm Dr. Brian Cole. I'm at Rush University Medical Center. And over the next few minutes, I'm going to discuss how we optimize allograft biology in sports medicine. We've spent a considerable amount of time looking at ways to optimize allograft incorporation and survivorship in our lab. And that really has been one of the current focuses in our Cartilage Research Center, looking at how we can improve allograft integration and survivorship over time. And while I will discuss how we look at other allografts and how we can improve biology there, I'll focus the first part of my talk on what we do today to optimize allograft biology. And there's a number of things that we've looked at from a translational perspective that have actually improved both in the laboratory and clinically our allograft survivorship. This includes gradual graft rewarming, submerging the graft during harvest to prevent cellular death, optimizing subchondral bone depth to minimize immunogenicity, using pulse lavage to further reduce immunogenicity, preparation with CO2 under high pressure, the carbojet, applying orthobiologics, and then various techniques to minimize impaction loads. So to start, gradual graft rewarming is something we looked at early on. And what we showed is that when these grafts, which are maintained at 4 degrees centigrade, are suddenly placed in very warm saline or room temperature saline, there actually is cellular apoptosis that occurs and a reduction in proteoglycan synthesis and increase in free radicals. What we now know is that if we gradually rewarm these grafts up to 37 with a transitional phase of 25 degrees centigrade, we can improve proteoglycan synthesis and reduce free radical formation of the graft. This is something that we recently stumbled upon. We had previously been harvesting our graft. Some people will use a jig, we'll do it freehand. And we would do it with just cold irrigation. That's how most of us will do it as we prepare the graft to place into the recipient socket. And what we recently showed is that when the graft is simply procured and processed on the back table with just irrigation from, say, a syringe, cell viability across the top of the graft decreases. So it's not just the edges, but there's actually a thermal effect that's negative across the top of the graft. So that's with traditional irrigation. And we now, with irrigation and submerging the graft completely, say on a sterile towel within a basin like this, can improve cellular viability both at the edges and across the surface of the graft. We know there is a significant amount of data that optimizing subchondral bone depth is also important, and this relates to immunogenicity. While the cartilage actually is viable and has minimal cellular immunogenicity from what we know as it's buried deep within the matrix, we think there's potentially a more hostile environment with the subchondral bone. So historically, unlike an osteochondral autograft, when we prepare an osteochondral allograft, our desire is to have the least amount of subchondral bone, but to still maintain a press fit. The literature from our lab and others has basically shown that with reduced amount of subchondral bone, we can improve the immunogenicity within the depths of the graft. We also know from other studies a similar finding that decreased graft thickness is associated with subchondral cyst formation that's reduced after allograft transplantation. So another advantage is basically looking at the cysts. We think there may be some subclinical response to the immunogenicity of the graft. We have also looked at the effects of pulse lavage. This was our first attempt to deep clean the graft. And what we've shown is that pulse lavage, and others have demonstrated the same, can cleanse the graft and reduce the marrow elements, which is really the goal of improving the immunogenicity of the graft and preventing that subclinical response that might otherwise occur that can lead to cyst formation and potentially early graft failure. We also completed another study that looked at the combination of saline lavage in sequence with high pressure CO2 using the carbojet. And what we showed is that when we used saline lavage, 2 to 3 liters under high pressure, and added 1 minute of high pressure CO2, this maximally reduced marrow elements, and it did so at a greater depth into the deep zones of the graft. And then what you can see here is graphically, you see a graph here on the left that still has visibly more marrow elements after being washed just with pulse lavage versus one that's been done in sequence, like you see on the right. But serendipitously, there's another effect which increases porosity. So this is a good way to demonstrate it. You can see at the left, this is application of bone marrow aspirin, an orthobiologic, without preparation. And on the right, with CO2 preparation, we can see increased porosity and uptake of, in this instance, bone marrow concentrate, which is our preferred go-to at the time of graft implantation. Now, Seth Sherman, in his lab and in collaboration with us, showed that with sequential deep cleaning, the kind of deep cleaning I'm discussing, that's using pulse lavage and then using carbojet to clean thereafter, that initially there was significant weight reduction before the application of the orthobiologic occurred. So getting rid of the saline content which basically mirrors the marrow. So eliminating that, doing this with in a sequence of first high pressure lavage, then using high pressure CO2, showed that there was significant weight reduction in these allografts in a benchtop testing. In addition, there was significant weight increases with applications of the orthobiologics. In other words, the amount of orthobiologic, given the increased porosity, increased compared to grafts that were just deep cleaned with high pressure lavage. We have also shown from a biologic perspective that looking at CT scans at 3, 6, and 12 months, that when these grafts were prepared intraoperatively and we added bone marrow concentrate, there was a reduction in large cyst formation and an increase in the smaller cysts, which we feel are less threatening. And we believe this may be related to the reduction in immunogenicity in the graft. We also showed that those patients who had increased porosity, increased uptake of bone marrow concentrate, had a significantly lower rate of subsequent surgeries for continued symptoms. And then finally, related to osteochondral allograft, the desire is to reduce impaction loads. And we know that with high levels of serial impaction, there will be downstream cellular apoptosis and reduction in cellular viability. So it's very important to sort of press fit the graft, and we will expand the recipient socket by about 250 microns using a dilator before press fitting the graft. And in this instance, we show a retention stitch, which can be used to reposition the graft if need be. Now, there are some other applications of using carbojet or high pressure CO2. So anytime we use allograft bone, where we're trying to reduce immunogenicity, get rid of marrow elements, and improve porosity, such as you see here, where we're optimizing meniscus allograft transplantation bone prior to application of bone marrow concentrate. Another example that we've researched is the use of a bone marrow concentrate in the setting of a BTB allograft, and we use it for autografts as well. We have shown in a randomized prospective study in 80 patients who underwent ACL reconstruction with and without bone marrow concentrate that MRI improved significantly at 3 months. And what we did show is that the ACL graft looked more like the control patella tendon in the same knee at 3 months. We also showed that the IKDCs were better at 9 months, and we still today don't exactly understand why the addition of bone marrow concentrate at time 0 improved IKDCs at 9 months, but we did see a modest difference of 82 versus 75 in their scores at that time point. Other areas of allograft application of high-pressure CO2 using the carbojet include allografts such as for glenoid reconstruction, as you see here. And the primary purpose, again, is to reduce the amount of marrow elements by deep cleaning the graft after pulse lavage, and then adding bone marrow concentrate prior to bone graft implementation. Another area that we currently use this is in glenoid preparation during just prior to glenoid cementation. This is a technique that was initially described by Dr. Matson, and in 2 or more of his papers, he discusses glenoid survivorship in concert with preparing the glenoid using high-pressure CO2 with a slightly different tip and using suction at the same time to get rid of marrow elements and blood at the time of cementation to improve the bone-cement interface. So in summary, deep cleaning allograft bone, we know that CO2 preparation reduces marrow elements. We believe it reduces anagenicity, and we have now shown that it improves graft porosity to maximize orthobiologic uptake. It's also important to note that orthobiologic applications such as bone marrow concentrate is actually considered on-label when it's used with allograft bone in this type of application. Thank you very much.
Brian, I wanted to ask you a couple questions. One, I thought and I know the three, you, Seth, and Adam have all done work here with the carbojet, but the tip and the data on that submerged graft harvest I think that was a great tip. That's something I'm going to definitely start implementing because I haven't done that. I've been doing that with dripping some fluid on there on the back table, and I think that's great. You had mentioned that you could see a lot of this uptake of the biologic after using the carbojet. Are you pretty much using BMAC for all these? Do you ever use PRP, or is this pretty much, if you're going to have biologic, you're going to use the BMAC? Is that kind of where you've gone with that?
It's interesting that most of the well, first of all, what's interesting is that it's considered basically on-label usage for orthobiologics when you're dealing with bone augmentation. That's the one place most of the use of orthobiologics in our world is actually off-label, but this is one area where it is considered on-label, but that doesn't mean it's reimbursed. So one of the big challenges is that this is an out-of-pocket expense for patients, so not everyone does it. If it were free or substantially reduced in cost, I would do it for everyone because I think the data is increasing compelling, especially as it relates to bone marrow concentrate. It may have nothing to do with the presence of MSCs. Most bone marrow concentrate preparations actually have an elevation in platelet fold increase. PRP for some systems is only often 0.5 to 1.5 fold increase, but in some of the bone marrow concentrate systems, it's 5 to 7 fold increase. So it probably relates basically to growth factor increase, maybe some paracrine effect and so forth. So I try to use it whenever possible. We don't really fully understand the role of these cysts. We did see a reduced reoperation rate in our prospective study that was randomized with and without bone marrow concentrate, which I thought was fascinating. We did see an increase in small cyst formation versus large cyst formation. So I think there's something there. We'll continue to follow these patients. The real challenge is that there still is a big disconnect between what we see by imaging and how patients do clinically. So it still remains to be seen if it's a definitive difference. But when you think about it, these are salvage cases. There's a lot of variability in biology. You can't really control the donor, nor the health of the graft once you get it. So we're always looking for ways to optimize the biology. And when I tell patients this is not about a regenerative phenomenon per se, but at least provision of growth factors may help with induction on the bone side, may reduce immunogenicity. That's some other variables that have been looked at in the presence of bone marrow concentrate and the cellular content. So there still is a lot to describe, but I do think there's something there.
Do we have any data on how much of the biologic is how much uptake we have of that compared to the dry weight after we've used the carbojet versus saying just using a lavage technique?
Yeah, some of the data I showed was from Seth's lab. It was a great study. It's something that it was sort of long overdue because visually it's very satisfying. I think in my talk, one of the videos I showed was where we're applying when we didn't deep clean with CO2, that oftentimes the biologic just kind of lays on top of the graft. And one of the first times I ever used carbojet on an allograft, it was like a sponge. It's incredibly, it basically just, it absorbs. It's like a dry cancella sponge, almost like demineralized bone. And it soaks up, a significant amount of bone marrow concentrate or whatever orthobiologic you use without it pooling on top or the sides of the graft. So when I deep clean it, I actually do it from the top and I do it from the sides as well. We've even gotten to the point now where we'll actually score the graft a little bit just to get more violation of the surface so that we can get more penetration. As far as the absolute weight increase, that's something that Seth's lab has looked at. So they did two things in that lab. One was to show that, when you look at saline content in the graft, how there's a reduction in weight when you serially clean it with both pulse lavage, then finish it with CO2, high pressure CO2 from the carbojet. But that the weight gain in terms of, they used a dye instead of an orthobiologic, but the weight gain was substantially better when it was serially cleaned with lavage and with high pressure CO2.
Yeah, it's pretty dramatic, the uptake. I had one 2 weeks ago on a lateral femoral condyle for an osteochondral allograft that used carbojet and then used some BMAC, and you kind of look around the room and you say, "Hey, look at this!" Everybody looks around; they can't believe the amount of uptake within that graft. I think obviously we're talking a lot about knees, but I think those, you presented some great stuff for some of the shoulder surgeons. What kind of tip is being used for people that are trying to prepare that all polyglenoid? What kind of tip are you attaching to the carbojet?
So there's another tip that is a reusable tip. I believe it's a reusable tip that is a longer tip that is a rounder end that fits in the hole. you got to be careful that you use suction at the same time. That it's on-label usage is not to use it in a closed system, so you got to be careful of that because it may drive marrow elements and so forth, and maybe the effects of gas, within the endosteum or with intramedullary. But there's enough. Basically, it escapes around the edges, but there's some glenoids, when you're preparing them that can be very bloody, and others are not bloody at all. But the objective is to get the improvement in the bone cement interface. I know arthroplasty surgeons. I don't do hip or knee arthroplasty. I think you do,
We
but
do
they've
some
been,
knees. Yeah.
yeah, use it in that application. I mean, it makes a whole lot of sense. Just like we're trying to get uptake, we're trying to improve porosity to get uptake of orthobiologics. Just the cement, the bone cement implant interface is really important. And when you think about it for glenoids, if you're using a pegged polyethylene glenoid, there's not a lot of surface area that gets contacted, so it's much more satisfying to get deeper penetration of the cement, that blush that you can get on X-ray. That can be improved if you can get rid of some of the marrow elements in the blood that's immediately in the hole prior to introducing the cement and then compressing the implant.
Yeah, no, those are great tips. I do a fair amount of shoulders also, and I'm putting in the the sponge in there and trying to dry it out and different things like that. But I'm going to definitely use that tip. I've got partners that have been using it on their total knees, and I do a fair amount of those now and then. So I think that's a great application. For your community surgeon, a lot of the conversation is, how do I get this into my ASC and things like that? And they say, hey, these are all great products, but how do I talk about cost and things like that? And what's your, for something like the Carbojet, what really isn't that expensive. I think it's $200 or roughly that. What's the conversation that you have, with the ASCs, where if somebody's having difficulty getting those types of things in there? And I know we talk about this with a lot of products, but what kind of conversation would you have or tell a community surgeon to have with their ASCs to get these types of, products into an outpatient surgery center?
Yeah, most centers, certainly the ones that are hospital-based, have a value add committee, or they have a value assessment committee that is usually multidisciplinary in nature and looks at these things. And there are several types of technologies. There are Me Too technologies, which basically are a race to the bottom for similar commoditized type things, but there's really nothing like this. And CO2 is in all of our ORs, so that hasn't been an issue. It's the tubing and the handle and the tip. And as you say, it's about $200 an instance. When you're dealing with for example, an allograft that's $10,000 to $12,000, and you're dealing with, basically a salvage type procedure that it depends upon integration and obviously we're looking for long-term survivorship. I think this is where the surgeon's opinion kind of matters, and most of our centers have not really said anything at all. And we're very involved with the financials of our centers, where everyone kind of knows individually what they spend and what their direct costs are for their cases. And this is one of those that I think it's just generally driven by the surgeon. It's not such an astronomical cost when you're comparing it to suture anchors that are $400 to $500 a piece on average, and some of the other things that we use in the OR almost indiscriminately. I think that this is a pretty easy one. When there's a VAC, when there's a value added committee that evaluates these, I basically would show them the data, and they're usually pretty open to that. Obviously, a $200 margin reduction on cases that are of this magnitude with purchase orders that are on the magnitude of $10,000 to $15,000 is usually something that is rounding error in that setting. It's not like this is a high volume procedure as well. The relative low volume procedure. So it hasn't, and I'm sort of on the financial side of our most of our surgical centers. This is one that kind of goes below the radar because the incremental cost isn't very high relative to the cost of the entire instance of care.
Sure. No, that makes a lot of sense. That's the nuts and bolts for a lot of surgeons. I think that's an easy discussion. I mean, we put a lot of anchors in on knees and shoulders and hips and different things like that. Sometimes we don't even think about it, right? And those are much more expensive than one of these devices. Are you using it, say, for a open single stage cartilage restoration procedure? Are you using it in the base of the bed that you've prepared?
We started doing that because it's, so we started doing that for our allograft, much like the glenoid. For our osteochondral allografts, we basically I try to make it so it's mobile. I can bring it up to the field, and we'll put BMAC in the base of it. I don't do it all the time because we're able to get a fair amount of VMAC into the implant, and I'll sometimes just bathe the area. And we do it under tourniquet, so doesn't seem to be a lot there. And the porosity is pretty good, but I will do it on occasion. It's equally satisfying when you do it on the patient side. You just don't want to do it in a closed system.
Okay. Well, guys, those are great pearls, and appreciate you answering those questions. Any other questions or tips or anything from either Brian or Seth regarding CarboJet? I know Seth's used that quite a bit, and Brian obviously does a lot of alignment procedures. But any other tips or tricks or any other comments about the MD3T system, tibial tubercle transfer, or utilizing CarboJet, or even tips and pearls with osteochondral allografts and things like that?
I would have just two quick questions for Brian that piqued my interest from your talk. One, how are you practically doing the gradual rewarming in the OR if you're doing that? I know that was
Yeah, that's a good question.
scientific study that you're doing. So how do you put that into real time?
Yeah, so we're not measuring temperature. So there's really cold saline, and we're just avoiding that. And we're just basically using, I don't have them use the very cold saline. I don't have them use anything warm, so it's basically a little bit cooler than room temperature because where they take it from. So it's not 37, it's not warm, and we're not using the really cold stuff. So we're not doing it in series. We're just not dumping it in anything that's warm or even room temperature. So it's sort of somewhere in between. I'm not even sure what temperatures we're at. When we studied in the lab, we went from 25 to 37, but you're right. Practically, we're just making sure that they're not giving us anything that's even remotely warm or have been sitting out in room temperature.
Brian, I think I understand the answer to this based on your prior comments, but with regard to where you take your BMAC from and why, can you just talk people through whether you're taking it from the distal femur, proximal tibia, or do you go to a separate site to the hip, and just kind of your thought process at this point?
If you look at CFU formation still to date, probably ASI or PSIS might have the highest in terms of CFU formation in culture, but that's not generally how these things are being used. And if MSCs matter based upon sort of characterization on surface markers, you're getting them in all different preparations, whether it's distal femur, proximal tibia, proximal humerus, anterior iliac crest, posterior iliac crest. So there are some marginal increases in those numbers, but I actually think it's the elevation of PRP that's probably as important as having anything that might or could be an MSC there. And, I think the role of PRP and MSCs is not only to provide growth factors in a paracrine effect, but it's also to recruit other the host MSCs into the area, which may have a positive impact as well. So I do it out of now because there have been a couple of studies that have looked at through quantification. There are not profound differences, and no one has ever shown any differences between the two. So at this juncture, I will take it from proximal tibia when I do knee procedures. I will take it from proximal humerus when I do shoulder procedures. And then for others, I will do it from ASIS and rarely PSIS just because I don't work in the prone position.
At this point, without further ado, I'd like to turn it over to Dr. Yankee.
Hi, everyone. My name's Adam Yankee from Rush University Medical Center. Thanks for allowing me to present on patellofemoral arthroplasty and specific the Kindamed implant. We already heard about some of the restorative options, and this is, one of the replacement options when things like that haven't worked, or sometimes you'll do this in conjunction with an osteotomy, like you can see in the picture here, which we can discuss as well. For this talk, we're going to try to go through the different types of arthroplasties and what are the benefits and drawbacks of the different ones, the different generations that have existed. We'll talk about specific indications and technique for the Kindamed implant. Then we'll talk a little bit about recovery, post-operative recovery after a patellofemoral arthroplasty, as well as the overall long-term outcomes, as well as post-operative imaging. And so we'll try to cover all this in the talk today. So first of all, for patellofemoral arthroplasty, usually we're trying to restore native anatomy. Almost all surgeries have pushed towards that. And any older versions that don't restore native anatomy usually have been improved by relying on the body's anatomy. And we know that in the patellofemoral joint, that anatomy can be fairly abnormal and pathologic to begin with, leading to the development of arthritis. One of the implant designs that you can hear about is an onlay design. So an onlay design usually has certain sizes for the femur, obviously certain sizes for the patella. These are the same patellar buttons you would see in a total knee. And one of the benefits here is that you can remove abnormal anatomy. So some of these are an anterior-based cut. They could be either intramedullary-based or have separate extramedullary guides, or even be robot-assisted. And it removes that anterior anatomy and then places new, quote unquote, normal anatomy. The downsides are you are removing some bone stock with this, and it can be more difficult to revise for that reason. But I found that one of the hardest parts about this surgery is that many implants will only go in one way to be able to get the proximal and distal transition correct, as well as the tracking correct. There's really only one way that implant will go in. And sometimes that works very well for patients, and sometimes it doesn't. And we'll get into the varied anatomy in the trochlea and how it can affect these. When we look at the opposite approach, these are inlay implants. So now we're going flush to the adjacent bone or cartilage, depending on if it has any arthritis adjacent to it. And we're not putting this on top of bone at all. This does decrease the amount of bone that is removed, and so it's only removed around the implant itself, and it's usually in a circumferential fashion. These have a similar button to the total knees. However, they do remove slightly less bone because some of them do not require a full patellar cut. So they can have a set number of sizes on the femur and then a set number of sizes on the patella. It is a relatively quick and easy surgery with less bone removal, but it does require you to try to match surrounding, sometimes abnormal anatomy with really what's normal anatomy of the implant, which can be challenging in patients that have significant patellofemoral arthritis. And so this would be on the other end of the spectrum from onlay versus inlay. When we look at outcomes of onlay versus inlay, unfortunately, a lot of these studies are fairly limited because they have relatively small cohorts, but it seemed like the patients generally did well in both groups. However, the more of the onlay group progressed to medial or lateral tibial femoral arthritis compared to the inlay. And this could be because the biomechanics are changing significantly. It could have also had to do with the overall indications for the implant. So unfortunately, none of these are level 1 studies. But I do think that this study and this review has an awesome figure. So this figure is, I think, really demonstrates the struggles you can have when you're performing an onlay prosthesis. And so when you look at A, where that red arrow is, you can see how if you have it tilted into too much flexion, you'll have a prominence proximally and sometimes get a jumping into the implant. I think that that's probably less commonly the issue. What happens in B is that if you try to not have overhang proximally when you put these implants in. And again, a lot of times you only have one position that you can put it in. And if the arthritis extends distally past the implant, sometimes you'll have this junction of prominent metal to bone and then cartilage, and actually the patella will jump as you go from flexion into extension. So instead of having a J sign from extension into flexion, which is what we think about most commonly, this will actually happen in the reverse setting. And then the other issue is that you could have anterior overstuffing, which I think is generally less of a significant abnormality compared to A and B. And then you can see how the inlay component in figure D demonstrates that it just doesn't cover the entire trochlea. So if you have a longer trochlea, more significant dysplasia, it just doesn't get to that area. And so those are the trade-offs. And that's one of the reasons I moved to the patient-matched implants, where because of the issues that you see, especially in A and B, I found it hard to get that perfect in every patient that came through the door. And I found that the custom implants decreased my risk of running into those problems. And so this is the example that we're going to go through today, and this is the Kindamed implant. And you can see that they're designed to match the patient's osseous topography of their trochlea. And if you just look at some of these examples, you'll see how some of them are much longer, some of them are much wider. And so the benefits here are you're actually not removing any bone. So we see this now in patient-matched implants and total shoulders, where you're just curetting any remaining cartilage away. And then you can place this down with the back side of it that matches the patient's native groove. And then it has a more anatomically appropriate groove on top of it with a custom drill guide. And so it makes the surgery very fast, easy, and reproducible, most importantly. And I would say that if you had to say a downside, you have to wait for these implants to be produced from the time you get the special CT scan, which we'll talk about. But that lead time is about 6 weeks. And for most patients that have been dealing with patellofemoral arthritis, that's not terribly unreasonable. And at least it's very predictable with regards to the manufacturing process. And so when we look at these different options, you can see that these are the correlating custom guides. And so you have the custom drill guide as well as the custom implant, making the femoral reconstruction really very straightforward. These are 3D reconstructions that are optional that I've asked for when I performed patellofemoral arthroplasty using the Kindamed implant. And it really shows you where the transition is going to be, what type of groove it's going to create. And you can see how it really follows the trochlear anatomy approximately. So you can see how these two implants are very different with regards to their width. This is a very narrow trochlea and it's long, whereas this one is very wide, where you have to capture the patella on a much larger basis. And to be able to capture this width with a standard implant, a lot of times you'll end up with an implant that might be long. And if it's long, then sometimes it'll overhang proximal laterally. And if you had an implant here that had to be this width, a lot of times you would be short in its overall length. And so that's where I'm saying it's very hard to get that correct on every patient every time when using standard implants. I'd like to go through some clinical cases just to show some standard indications and what we look at for trying to get as strict of indications as possible, and also some surgical technique. So these are 3 patients of mine. This is a lot of detail, but I want to just give you some broad strokes. On the left, this is a young patient, 29 years old, and I have unfortunately done a decent amount of patellofemoral arthroplasties in people in their 20s or 30s, which is a different conversation than the people in their 70s. But she's had prior instability, tibial tubercle osteotomy, MPFL, failing conservative management, and retropatellar pain that is due to dysplastic patellofemoral arthritis. The lady in the middle is 56-year-old, fell directly on her knee, a little bit more typical retropatellar isolated arthritis, and we'll get into the imaging. And then the last patient was a 67-year-old male who had a patella fracture. He had it treated with ORIF 40 years ago, developed retropatellar arthritis, and then had pain in that area. So his was post-traumatic, but significantly long time ago, so chronic in nature by the time of presentation. The first thing is standing weight-bearing x-rays in extension and flexion. So Rosenberg PA flexion views are extremely important. You will miss arthritis if you don't get that in 30% of patients, and you will also miss it if you're not getting weight-bearing views. You can see some very small osteophytes forming on the 2 patients that were slightly older, but otherwise they really have well-preserved joint space. I do like to back this up with an MRI on every patient that I do a patellofemoral arthroplasty on. Unfortunately, I would say I think there's a significant correlation of patellofemoral arthritis and medial meniscal root tears. And so you really want to make sure that they're not going to fail because of progression to tibial femoral arthritis down the road. And so here you can see in the older gentleman, he's got some small lateral-based osteophytes. But again, you can have osteophytes just from having arthritis in the knee that's retropatellar. You have inflamed synovium, and that can affect the whole joint, which can be osteophyte formation. So I'd call this one maybe Kellgren-Lawrence 2 at the worst, and the rest are 1 or less. And that's really where you want to be, is somewhere in the 1 or less category. I think it's also really helpful to get used to looking at lateral x-rays. Lateral x-rays can be even easier to pick up significant arthritis than the merchant view. And a lot of times the merchant views, as you can tell from these are all obtained at our institution. Unfortunately, the consistency of the angle and the degree of flexion that they're taken at is not as conserved as a lot of us would like. And so on the left, you can see significant dysplasia. On the middle patient, you can actually see significant dysplasia. So both of these, let me get my cursor back on here. Both of these have a significant trochlear spur here up at the top. And then when you look at their axial views, sometimes it may not look too significant, but when you get the MRIs, because the x-rays can be so sensitive to the degree of flexion that they're taken at, the MRIs are usually much worse than the x-rays. So this is clearly bone-on-bone arthritis, but we just didn't capture it with that x-ray. Once the patient's indicated has no tibial femoral arthritis and an MRI showing no significant meniscal disease, we get a custom CT scan that's specific to the Kindamed implant so that we can get 3-dimensional information and to be able to recreate normal anatomy for these patients. And again, these are just 2 different patients to show you the difference in the grooves and the difference in overall dysplasia. And you can see that this patient on the left the groove is really significantly medial. And so you can see how it comes off almost at an angle here. And so you really want to put that more in the middle. And you can see that when the implant is created, the groove is central. So this is an example of the patient that we saw on the left here. And so the groove for this patient sitting somewhere over here, far medial, but the actual implant, the groove here you can see sits directly in the middle. And so the undersurface of the implant does not match the superior surface of the implant. And this is kept as thin as possible so that we're not adding significant material between that compartment. This is a brief surgical technique video. You can see that the incision size is essentially the length of the patella. You just need enough room to get the patella everted, and then you need enough room to get the cutting guide in, which you'll see here. And that's usually less than 7 centimeters. Once we do this, I perform a lateral lengthening in all of my patients. And so here we've cut down at least 1 centimeter along the LPFL, or along the lateral retinaculum. And we do this first because it also helps evert the patella. And then after this is complete, we then move on to our medial arthrotomy, where we then evert it. You can use a caliper to determine the depth of the patella. And a lot of times in these patients with significant arthritis, the lateral facet's very thin, around 10 millimeters, sometimes even less. So we're removing basically no bone there. We'll remove peripheral osteophytes and usually perform a lateral facetectomy, which will help from that lateral facet engaging in any aspect of the far lateral aspect of the trochlea. I then perform a freehand cut, and we try to keep this at least 14 millimeters to 15 millimeters on the medial side. And we perform this here in a freehand fashion, or you can use a guide if you prefer. Again, better to measure twice and cut once and not take off too much laterally. Here we're using our patellar button when we're drilling our 3 lug holes, and this is sized in a standard fashion like a total knee, where you try to keep it medial and distal. We then move over to the trochlear component. So here we have a mock-up of the distal femur that we use intraoperatively, and you can see where it's going to sit. And you want to get an idea of where it sits distally relative to the notch. And so you can see that here, that distance. And then you also want to look proximally to see where it sits relative to the proximal aspect of the trochlea, which is usually very little overlap there. And I add 2 extra holes here because I don't want to use our final holes. And so when I put this in place, it's currently in place temporarily just to determine the outline of where the implant will be. And it's not going to sit perfectly because there's still some cartilage left. So what we do is we use these 2 separate holes that we drill that are not the standard manufacturer holes, which are what are here on the side. We mark along here distally. We double check that distance to the notch. And now that this is really held in place, we can flex and extend the knee and really make sure we have it in a position that we like, that there's only 1 millimeter of our trochlea extending proximally here. And then we mark out the distal aspect of the implant with a marking pen. You can then also cut this with a knife so that you have a nice clean line, so you have a smooth transition. Once we take this out, we can then remove any remaining cartilage. You can see that laterally there's significant sclerotic bone, but a lot of times there's still some cartilage either distally or medially. After we do a crosshatch pattern with a knife, we can remove this using a curette until we get to the subchondral bone throughout, making sure there's a really nice transition area distally that's very sharp and well demarcated. Now we use the other holes in case this is in a slightly different position to place the bony component here. And then we can use a drill, which the drill for the manufacturer has a positive stop that creates our 3 lug holes that, again, we can copiously irrigate to remove any bone debris that's in the holes themselves. If it is sclerotic, you can use the pins to create a little bit more areas for interdigitation. And then we use cement of choice. Again, it's good to have the cement a little bit on the firm side. Because this implant has a lot of give, there's about 4 millimeters of offset for cement mantle. You want to make sure that after you impact it, you're not moving it too much, especially if your cement is slightly liquid. One of the other benefits of doing this is that once you impact it in place and remove the excess cement, if you bring the knee into full hyperextension, the fat pad in the anterior tibia will help reduce this anterior aspect of the implant. So here you can see that it's got bone all the way around the edge of it. It's really easy to see. And while we're doing the patella, we have somebody else holding the knee down in hyperextension. And here you irrigate and then use cement and then use a standard patellar clamp here to hold this in place until the cement has fully cured. We then try to close the medial retinaculum, typically with the knee in about 30 degrees of flexion. And once the entire medial retinaculum is closed, we then close that lateral lengthening, which you can see here at 30 degrees of flexion. We want to check full motion here. Nothing that we do should over tighten it or over constrain it. And we don't want patients to lose range of motion, which I think can happen if you try to make the retinaculum too tight. So when we look at the postoperative care and outcomes for patellofemoral arthroplasty and this implant specifically, usually the recovery is generally going to be the same. So we just try to keep the incision clean, dry, and intact. I work on full range of motion right away. I have no restrictions to range of motion whatsoever. They can weight bear as tolerated immediately with crutches being optional. And they work with a brace locked in full extension until they can do a quad set without a lag out of the brace. And that's just to prevent them from collapsing. So if they have quad shutdown, we don't want anybody to have a fall in the postoperative period. At 6 to 12 weeks, we want them to have full range of motion at the 6-week period. We get rid of the brace at 6 weeks if they haven't already. And then we start to return to activities of daily living. And beyond 12 weeks and up to even 6 months, hopefully they're getting back to all their activities as tolerated. The whole idea of how much you let them get back to you, do you let them run and things like that? It's just a conversation with the patient. And actually, the younger the patient is, the more I want them to be restrictive with activity, because the longer I'd like it to last for them. And so that means running, jumping, impact activities. I would view it like tires on a car. If you take a car on a track and you drive it like crazy, you're just going to wear the tires out faster. Postoperatively, I think this implant's important to understand what it looks like in postoperative imaging. Now, this lateral view is pretty helpful because you can see this was a very dysplastic patient. This was the younger lady that we had on the example on the left to begin with. She has a very large supratrochlear spur, so that makes her implant sit more anterior. And sometimes it'll look like your implant's just floating in the air because you have it in too much flexion on X-ray, but it's not. It's on the trochlea, and a lot of times that's actually the proximal medial aspect of the trochlea when patients have significant dysplasia. Something else that I have noticed with this implant that's important to talk to is patients. So here you can see this young girl's preoperative and postoperative X-ray. And so some people say my knee generally looks a little bit bigger than it did prior to surgery. And I think that's a real finding. So, you're taking somebody whose patella is so thin that you basically can't remove any bone off of it. You're adding the thickness of a patellar button. And then you have some thickness that you're adding from the implant itself. And while I think there's no clinical relevance to this, I do think that it's something that's important to tell patients, especially if they have dysplasia. If they don't have dysplasia, if they don't have significant lateral wear that's fairly erosive patellofemoral arthritis, then this conversation is really irrelevant because I would say that those relative changes are not terribly significant. And part of this is because this is an example of a patient that's dysplastic. You can see that they have a flat trochlea, and then you're basically adding the component on top to create a groove. And then you can see on this patient too that the patella sits a little bit of an angle because you remove more bone preferentially medially than laterally. And so you're adding some material there as well for the patellar button. This is a broad strokes review from JAOS that looked at overall implant survival of patellofemoral arthroplasty, all comers across many different databases. And essentially, it was about 85% at 10 years had not had repeat surgery and 66% at 20 years. I always tell patients that if we fail within the first 2 to 5 years, then we made an indication error. And if we failed beyond 10 to 15 years, then maybe that's something that we can improve on with implants or overall fixation. But we really don't want somebody having another surgery within the first 5 years. And then if we look at why we fail, the different colors here demonstrate the low and the high ends of what's reported. And so tibial femoral arthritis accounts for almost half of the reasons that people fail. So they move on to developing tibial femoral arthritis, and then they have a total knee arthroplasty. Continued pain is a difficult one to have as a failure. 20, depending on the papers you read, 20 to 30% of total knees will still have pain after. So I think it's easy to blame an unresurfaced tibiofemoral joint for continued pain, but we all know there's many other sources for pain in the knee besides the cartilage and the bone themselves. And then luckily, aseptic loosening, patellar maltracking, and infection are relatively uncommon. I think that patellofemoral maltracking is the one that I still struggle with a little bit, and we'll talk about that in a second. This is an example of that gentleman that we had on the right that had prior ORIF. He had very clear bone-on-bone retropatellar arthritis. This was his preoperative MRI. You could see that his menisci really looked generally very good. He has this lateral osteophyte that we saw before. And then he had, at about 8 to 9 months post-surgery, an acute event, a popping sensation in the knee, and a large effusion. And then unfortunately, this was his MRI at that time. And you could see that he knocked off a large piece of cartilage off of his medial femoral condyle. His medial meniscus didn't look great for sure. And he definitely had some progression of a degenerative medial meniscus tear there. But it really looked pretty darn good at the time of his original MRI preoperatively. And so, yeah, he did have a lot of swelling. He did have post-operative pain, and we actually took him back for a scope, cleaned this up, just like you might do for somebody that doesn't have tibial femoral arthritis because it hadn't set in yet. And he's now about 2.5 years out and still has not converted to a total knee. So this is one that certainly could have become a total knee, but sometimes you can kind of sneak past it, or at least get a few more years, hopefully, out of it. This is a patient that had an isolated patellofemoral arthroplasty. She had significant dysplasia pre-op and a relatively lateralized tibial tubercle. And unfortunately, she developed this jumping J sign post-operatively. This was not present at the time of surgery. It tracked very normally at the time of surgery. Significant discussion with this patient about whether or not she should have a total knee or a tibial tubercle osteotomy and an MPFL. This was actually that patient that we saw in the middle group of the 3 cases that I put up originally. And so she had zero tibial femoral arthritis whatsoever in a very normal MRI. And so I sent her to one of my colleagues that does total knees, and he agreed that after a conversation with her that we would try to do this realignment, which luckily worked out really well for her. But this is something we can talk about. But I think this is an outcome that's very difficult to predict when a patient's asleep on the operating table with an inactive quad. But that's another failure mechanism that I think we can decrease. Kindamed has a few studies looking at its outcomes. This was one for 25 patients, showed that at 6 years, there was generally significant improvements well beyond MCID for patellofemoral arthroplasty for looking at KOOS outcomes. Looking at another study here with longer-term outcomes at 11.3 years, demonstrated no revisions, and most patients were very satisfied. If we look here at some of the primary outcomes, 25 of them were very satisfied as opposed to anything less than that out of 25. None of them felt their knee was weak or unstable, and all of them said that they would have the same surgery again if they had it to do over. And so the outcomes seem to be good, but certainly larger scale outcomes would be helpful for this and really for all implants. Patient-matched implants are quick, easy, reliable, and reproducible surgery for patients that have variable anatomy. Surgical indications will always be king for any patellofemoral arthroplasty to have long-term success. And patellofemoral tracking abnormalities, I think, can still be a struggle. One of my colleagues that does a lot of patellofemoral arthroplasty, I was trying to learn from her, and I said, how do you know when you should add a tibial tubercle osteotomy after you've done a patellofemoral arthroplasty? And they said when they have abnormal tracking post-operatively. And I was like, well, that's where I am today. So hopefully we can all learn from that and try to improve. So thank you very much for your time.
Adam, that was a great talk that you gave there. I think the last 5 minutes you talked a lot about, um, when do we know to bail to either a total knee or things like that. And you talked about a 29-year-old, a 56-year-old, and a 67-year-old, and obviously that conversation is going to be a little different depending on the age of the patient. But I'd like to dive a little deeper. I mean, how do you decide how much concomitant pathology you're going to accept? And a lot of that is going to have to do with their age, but how much wear, say, in the medial and lateral compartments, or how much are you willing to accept and still undertake the patellofemoral replacement?
In the tibiofemoral joint, I would say I accept very little, except for in very specific situations, which we can get into. So if you have somebody that you think is biologically not going to outlive the implant. So that you think that the 15 years of an outcome with your implant will outlast the patient, then I think you really want to get strict indications. If they have any signs of early arthritis and they're already in 75, 80 years old, then I think the only reason to do that is if there's some significant risk of the overall intervention of a total knee compared to a patellofemoral arthroplasty. But in that setting, you do want it to last the rest of their life. And if there's no tibial arthritis there at all, then of course I think they would still be a good candidate. When we have patients that are younger, I've had some patients with significant lateral tibial disease that you would call Kellgren-Lawrence grade 2 or 3, up to even 50% joint space loss, but they also have significant valgus. I've done distal femoral osteotomies with patellofemoral arthroplasties in those patients because you get their tracking improved and you offload them, as well as resurfacing the joint with less overall metal and plastic burden. And then, finally, that first girl that we talked about, the young girl, her option for biologic reconstruction would be a shell allograft. And so that's a full total knee cut of the trochlea and of the patella. And we did a comparative cohort study looking at plugs versus shells with Jack Farr in our patients. And the failure rate was almost 30% at 10 years of the shell group. And so it's a conversation to have with the patient of, you get in that setting, even though she was young, she had already had like 10 surgeries in the last 10 years. And she said, I just want whatever is going to give me the most reliable next 10 to 15 years. And certainly that was the arthroplasty for her.
Sure. I think it's interesting, the patellofemoral joint, it's like a fingerprint, right? Like no two people have the exact same fingerprint, just like, especially with the trochlea, and no two people have the same trochlea in the same patella. And the ability to really dial that in is one of the great things about the Kindamed system. Are you finding, we get this CT scan and we kind of get a basic idea of how we want to build out the custom plan. When you get that back, are you finding yourself changing that or tweaking from what you get back very often? I mean, if you're really worried about, say, that person that has a little patella alta, or maybe they do have a real flat trochlea, are you finding yourself changing that so maybe you can get a little better lateral lip, or changing where you put the patella even?
Yeah, those are great questions. So I'll start with the flat trochlea one because I think it's maybe the easiest. Luckily, they're always matching the superior surface to the patellar button radius of curvature. So you will always have basically that same trochlear groove anatomy, regardless of what you're dealing with underneath. And so the only reason you wouldn't have that is if you ask them to do something different there. When patients do have alta, or they do have a really dysplastic trochlea with a large bump, I think those are situations where you might ask for a longer trochlea and more length there to be able to make sure that you have a smooth transition. If they are really anterior, so if you have a dysplastic trochlea with alta, which is kind of what you're describing, that can be a recipe for disaster because, again, you don't want to have post-operative maltracking. And two of the things that are red alerts for me are when you have a patient preoperatively that has a jumping J sign. I feel like I will not eliminate that by giving them a normal trochlea. You might reduce it to some extent, but sometimes you'll actually accentuate it. And so those are the patients that I talk to about adding a tibial tubercle osteotomy with the patellofemoral arthroplasty. The other group that's a little trickier, but certainly can exist, are people that are chronic lateral maltrackers. So they start lateral, but they don't have a J sign. They just stay out lateral the entire time. And those are patients like that lady that I showed in the middle example that had the jump post-op. So now you took somebody that starts lateral, finishes lateral. Now she starts lateral and finishes central. And it can be hard to get that from just rebalancing soft tissues. And so the only other thing I think you can do in that setting, if you're trying to stay away from a TTO, is you can ask for the groove basically angle to come out and be in more valgus so that the entrance to the groove for the implant is more proximal lateral and allows it to transition over in a little bit more of a smooth fashion. So I think those are the main cases I would ask for any changes.
You add an MPFL reconstruction to any of these patients that are like that, where you're a little worried maybe they are tracking out laterally and you want to give a little more restraint there?
Yeah, they have we still see some people that had this problem because they had instability originally. Then they developed arthritis and they still say my kneecap feels loose, and you feel them and they're objectively still pretty loose. Then for those patients, I will add MPFL and do a formal reconstruction as opposed to relying on an imbrication of the medial soft tissues. I would say if somebody has really abnormal tracking, so like a large jumping J sign, or they just sit completely out laterally throughout all of flexion, I worry that soft tissue alone won't be able to pull them over and that you gotta kind of line up the putt and then just stabilize it. And I think that's the trick is figuring out who's who there. And that's certainly something we all still need some help with.
Sure. Maybe you give us a couple of tips when you're preparing that defect. You've put your you've put your instrumentation on. You've drilled some of your holes to keep the femoral guide on there. We've got that large curette that we use that we can clean off the cartilage. Do you ever find yourself using anything else? Sometimes you get into that burnished bone, or it's just not sitting down quite as much as you want it to. Do you ever add a little burr or anything just to kind of touch up those areas at all?
I think
We obviously
one of
don't
the,
want to alter the anatomy, right? This is a
yes.
custom. We want to follow their anatomy, but do you ever find yourself doing that?
Well, that's what's nice about some of their plans, which I didn't show here, but they will give you a plan that shows all the bone you can remove without causing any problems. And a lot of that tends to be peripheral osteophytes. And so if it is within the implant area itself, I try not to burr that down. Now, if you have a small bump that you want to get rid of and it's like 10 millimeters in diameter, that's going to get filled with cement. I don't think that's going to affect how it gets seated. You can see with sclerotic bone, I do like to drill holes to get a little more interdigitation. But I think something about the curette size that's a small point, but maybe helpful is sometimes you go from sclerotic bone to soft bone when you go from the arthritic to the non-arthritic area. And I think that using the large curette distributes your force and has overall less peak pressure, and you're less likely to gouge into the bone by accident. So I try to do as much as I can with the large one. And if there's really stubborn areas, then I move to the small one to try to get that as smooth as possible throughout.
Sure. I thought your presentation on how you prepare your patella was great. I mean, I think that follows a lot of the same principles as our arthroplasty colleagues with, a fascectomy and cleaning out the marginal osteophytes or kind of a patelloplasty, if you will, and also doing some of the release laterally. I guess the question is how much after you've done all those things, how much time do you think you're saving in the operating room by using this custom implant that takes obviously less instrumentation, things like that? How much? I mean, we're in a world where we're trying to save as much time and be as efficient as we can in the operating room. How much time do you think you're saving on a pretty straightforward patient by using the custom implant?
Yeah, I think even on a straightforward patient, it moved it from about 45 minutes to 30 minutes. So I think that 15 minutes easy and less worry throughout the case. That it just is more reproducible and reliable. And I think that's what all of us want in the operating room. And something I noticed is that I used to use an intramedullary system as well as a few other systems prior and inlay. I've used many different systems and sometimes it's hard to even get the instrumentation in. The overall visualization with instrumentation can be difficult. The size of the incision gets much, much larger. And a lot of us know that the incision size doesn't correlate with clinical outcomes and functional outcomes. But a lot of patients prefer to not have a very large incision if possible, especially if you can do just as good of a job with a smaller incision. And I think that getting used to placing the drill guide so that you know where to remove the cartilage is probably the number one learning point of this implant design. And once you get that part figured out, the rest of it's all surgical technique that all of us are used to.
Sure. Adam, do you have any other tips or pearls you can think of that the audience would like to learn and to hear about?
I think, like you said, the conversation with the patient is paramount. And so the world of patellar resurfacing is all over the map. There's people that say you can do a total knee and leave it alone. And then there's 50% of those patients, if you resurface the patella, they end up having less pain. So I think we all know it can be a source of pain and discomfort. Tibial arthritis can develop. I think you just be very thoughtful and complete in your evaluation and you can practice this technique before you actually perform it in case you have concerns about it. And if you do all of that stuff, you'll generally have patients that are very happy with it and have excellent outcomes and generally less pain because they have less bone removal and less bony work that's done intraoperatively. So I think their immediate post-op recovery is much easier. And just pay attention to the tracking. I think that if you can get bit with any system, that's the thing that you really have to pay attention to also.
Yeah, you alluded to it briefly as you were talking to us, but you put any restrictions on these patients going forward? I know everybody's a little different, but is there any hard nose, skiing or running or anything like that?
I actually don't mind occasional impact activities. So if you're going to ski, I actually think that that's fine. If you're going to do running as your primary source of recreational activity and aerobic cardio activity, like marathons, obviously that's an extreme example, but even running multiple miles a day, every day, I don't think that's a good idea. I just think that the chance of that loosening things is high enough that, or wearing your poly, that especially if you're younger, I don't think it's a good idea. If you're unlikely to outlive the implant, which again, I say that to patients, it's a somewhat morbid way to look at it, but I think we all realistically are thinking that. And then I think you could probably push it a little bit more. Obviously, a lot of those patients are just looking for daily life improvements at that point. But it is a conversation, and I try to limit from repeated, regular impact activity.
Well, thanks, guys. Really appreciate those pearls and answering those questions. Would like to thank the three surgeons that were a part of the Kindamed knee preservation meeting tonight and presentation. We heard from three world-class surgeons, and Seth Sherman, Brian Cole, and Adam Yankee. I've had the opportunity to use all three of these products. They are very intuitive. I think for surgeons that are, have had some angst about some of these procedures, they're very easy to implement into your practice. And I think it's going to take us through that whole continuum from the person that we're worried about alignment or cartilage restoration, things like that, and then all the way to the folks that are going to need some sort of patellofemoral replacement. And allows us to customize, each step of the way. The MD3T system, we can correct this in so many different planes, as Dr. Sherman showed us. With the Kindamed patellofemoral system, that is 3D printed, and we can make decisions on where we want to place that based off the scans. And these are easily implemented to any surgeon's practice, whether it's the sports surgeon or the knee preservation specialist. Want to thank Vineet Saran tonight for hosting this, and hope everybody has a good night.